Hi, everyone, and welcome back to Burn the Rulebook podcast. This is the podcast where we break down everything you were never taught about menopause, mental health, and relationships one truth at a time. I'm Rachel Boyle, a licensed couples therapist, sex therapist, and certified menopause specialist. This podcast helps you understand what is actually happening to your body, mind, and relationships, and gives you real tools to move through life with clarity, calm, and connection. Let's get started. Hi, everybody, and welcome back to Burn the Rulebook podcast. Today, we're going to be talking about painful sex and dryness and UTIs and perimenopause. And we're specifically going to talk about how it likely might be the Genitourinary Syndrome of Menopause. And we're going to talk about how to protect your relationship while you treat it. So if sex suddenly burns, if you're drier than you've ever been, let's say you're peeing more, you're getting mystery UTIs, and lube isn't fixing it, it might not be a you problem or a relationship problem. It might be the Genitourinary Syndrome of Menopause, or GSM. And it's completely treatable, and most women are not aware of it. So today I'm going to add in the piece that most people skip, which is how GSM can quietly wreck your connection and your intimate relationship. And it's not because you're doing something wrong or your partner is doing anything wrong, but because there can be so much pain and shame and misunderstanding, which creates a couple cycle that can lead to conflict or even to distancing in the relationship. So first of all, we're going to talk about what GSM, the Genitourinary Syndrome of Menopause, is. And that is a genital, sexual, and urinary symptoms related to declining estrogen and androgen concentrations in the genitourinary tract during the perimenopause and menopause time. So basically what that means is that your vulva, specifically your labia minora, your clitoris, your vaginal canal, your bladder, they lose estrogen and testosterone. So remember, your estrogen fluctuates wildly in perimenopause, and your testosterone starts a steady decline in your 30s. So those are hormone-dependent tissues. And if they're not treated with estrogen, then what happens is they dry up. They can become irritable. They can get like little micro tears in there, so it feels like tissue paper. Some women even say that it feels irritable if they're wiping after they pee. And the clitoris can eventually reabsorb. So can the labia minora. The clitoris can get clitoral adhesions. And so much of this can cause pain with sex. It can cause embarrassment and disconnection in relationship. So a lot of times women will think, my body's falling apart, or maybe I'm not attracted to my partner anymore because I don't want to have sex, or maybe we're just not compatible. When in reality, it may be GSM that is showing up and creating a relationship problem. So here's what I see frequently is that whenever a woman starts having GSM, and maybe she's just having some mild irritation, a little discomfort, so she starts avoiding sex, not because she doesn't want to have sex with her partner, but because over time, her nervous system subconsciously learns that sex equals pain or sex equals discomfort. So unconsciously, you start pulling away from your partner. And a lot of women start to avoid all physical intimacy, like holding hands, hugging, kissing, because they think it's going to lead to sex. And if sex is feeling uncomfortable, then they don't want to do anything that leads to sex. So another thing that I just want to say is that women have historically, from the time they were born and over hundreds of years of women's existence, their pain and discomfort have been minimized. So when I say the word discomfort or uncomfortability, it's important to know that you should not be feeling any pain or uncomfortability during sex. And if you are, then there are some things that can be adjusted so that you don't feel that. Because if you are feeling any kind of pain or uncomfortability, your body will unconsciously start to pull away. That's just how human nervous systems have developed over time to keep us alive and safe. The more you withdraw, the more your partner will start to pursue. You might feel like they're pressuring you. They might be asking you questions. And the more they pursue, the more you withdraw. That's one dynamic. That's not great. The other dynamic is the more you withdraw, the more they withdraw. And that can lead to shame, fear, dread, resentment. It can lead to a cold, sterile relationship. And no one wants to be having sex in a cold, sterile relationship. So over time, what can happen is desire can actually drop for both people, not because your love has disappeared, but because you as a couple are stuck in this protection loop. You're protecting yourself from physical pain, and your partners are protecting themselves from the emotional pain of what they perceive as rejection. And their protection is triggering you to protect yourself even more. So that cycle needs to be identified and talked about, and you need to get some help so that you're not feeling uncomfortable or in pain anymore. I want to be really clear that there is this idea out there that you have to use it or lose it. So if you're having pain, you don't want to push through that. You don't want to just try more. You want to figure out what's causing the pain or the uncomfortability so that you can get it treated so you can start having sex that feels good again. So a lot of times women don't get a proper diagnosis. Number one, because they're taught to deal with discomfort and that discomfort is normal. Or number two, they go to their doctor and their doctor isn't aware of what's going on, so they're not getting accurate treatment. Many people are told just use lube and they think that's supposed to work, but that's not going to help with the genitourinary syndrome of menopause because lube is not going to help you rebuild the collagen and repair the tissue. Vaginal estrogen will help you with that. Also, a lot of women won't bring it up because they're embarrassed about it and they think that it's normal to just suffer. So the first thing I'm going to talk to you about the different kind of treatment that you can get. Localized estrogen therapy. It's very low dose. It goes inside the vagina. The vagina wall the vagina shares a wall with a bladder, so that's going to also help with any bladder issues that you have been having. It also is going to help with rebuilding the collagen and the tissues of the vulva. There's all different kinds of vaginal estrogen that you can get. But if you really are having some irritation, you really want to get with someone who knows what they're doing in women's sexual health, because there's different forms of vaginal estrogen that you can use depending on what your issues are. Also, it's important to note that the FDA just removed the black box warning on low dose vaginal estrogen. And so this is going to help a lot of women feel a lot better about using it, because used to you would get the box and there's like all these warnings about how it's going to cause breast cancer, it's going to cause you to have a blood clot, or all these other scary things. And what they found is that is actually not true. And the dose is so low that used as directed, it's not going to go systemic. The primary treatment for GSM is going to be vaginal estrogen, pelvic floor therapy, and if vaginal estrogen doesn't work, then there's a product called Intrarosa, which is an FDA approved vaginal suppository. And DHEA is the precursor for estrogen and testosterone, because some women's vulvas need a little testosterone in order for them to function optimally. But you finding a very trained, qualified women's sexual medicine doctor is going to be so helpful for you, because they're going to be able to identify and treat what's going on, especially if you're in perimenopause, because things are so chaotic in perimenopause that you need someone who's really well trained. Also, getting someone who's very, very well trained in pelvic floor physical therapy, that can help if you're having bladder leakage, or if you're having a tight pelvic floor, that can also cause pain. So, as women, we're taught tighten the pelvic floor, but at the end of the day, if it's too tight and it's constantly tight, then that's going to cause uncomfortability. So there's actually exercises to relax your pelvic floor if that's what's needed, but really only a very well-trained PT is going to be able to tell you that. The next thing that I want you to do is use a script with your partner. So what I want you to do is, once you find out what's going on with you, you need to let your partner in on what's going on. So tell your partner, hey, I'm not rejecting you. I'm just feeling some pain and some irritation that I didn't used to have. And what I really want is to feel close with you. But what's going on is, because I feel this pain or this discomfort, my body is unconsciously pulling away. And so what I'd like for us to do is to start talking about, hey, what can we do about this? So the first thing that I'm going to do is to make an appointment and see a professional so that I can start to get this treated. What would be super helpful for me is if you can take the pressure off, because when I feel pressure, my body braces and it increases pain and avoidance. So as a favor to me, if you wouldn't mind to stop putting pressure on me to have sex. And here's what I can also do, is that I really do want to be open to having intimacy with you, as long as it doesn't involve penetration for now. So I'm open to hugging, kissing, touching, oral sex, whatever it is that you're good with, be open with it. I'm talking to you as the woman. This is not part of the script. Whatever you're good with, share that with your partner so that you're providing a solution so that they can feel enrolled into being a teammate with you. Okay, so there was this study that was done, and it was done in August of 2025, and I've got it right here. It's called the Genitourinary Syndrome of Menopause and Sexual Function, Partner Knowledge, and the Impact on Coupled Sexual Relationships. So this is what they found, is that they did a study with 266 couples aged 50 to 70 years. And what they found was the prevalence of GSM was about 75%. Okay, that's pretty high. That's like most women have GSM. And that vaginal dryness was present in 44%. Dyspareunia, which is pain with sex, was almost 59%. And only about 49% of these women's partners knew about the GSM and the symptoms. Vaginal discomfort led to the loss of desire, and women avoided intercourse because they were concerned about pain. So this GSM is super important because if it's not known about it, if it's not treated, it's wrecking relationships. Also, another fun fact is GSM used to be called vaginal atrophy, right? Because you've probably seen on TikTok all the little videos that are talking about the labia minora being reabsorbed into your body. Also, the clitoris can shrink. So it used to be called vaginal atrophy, and before that it was called the senile vagina. So luckily we now have a better name for it, which is the Genitourinary Syndrome of Menopause. So if you take nothing else from this, know that painful sex in perimenopause deserves evaluation. Uncomfortable sex, right? Because as women we're taught, we are supposed to push through uncomfortability. Uncomfortable sex in perimenopause or menopause deserves an evaluation by a trained professional. And this is not something that you just want to push through. You want to treat the condition so that you can get back to feeling great in your relationship, feeling close with your partner, and to be able to have really good sex. So if you found any of this information to be helpful for you or for a friend, give me a like or forward this on to some other woman that you think might be helpful. And thanks again for listening, and see you next time. Thanks for spending time with me today. I hope you found something helpful, validating, or just a little more human in our conversation. Remember, while I'm a licensed therapist, I'm not your therapist, and I'm not a medical doctor. This podcast is for informational and educational purposes only and does not constitute medical or mental health advice. For personalized care, please consult with a licensed healthcare provider or mental health professional trained in the area you're seeking support. You deserve expert guidance that's tailored just for you.